So we have 1 minute to go, so we can, I think we'll start 2 minutes past, just to give people time to connect. So I see the attendees are slowly going up. So maybe 1 more minute before we start, everyone.
How many so far?
Not many, just 6 so far, but I'm sure more will connect.
And the 6 of us makes 12. That's a nice number.
16 overall.
Will Teresa introduce all speakers at the very beginning, or are we going to introduce one by one?
So I think we can introduce one by one.
So Ernesto, you are leading the whole event. That's why I'm with the opening remarks and everything in your hands.
And then you fly to Moscow.
So not directly, virtually.
Okay, everyone, I think we're all set to begin. Welcome to the special NTB webinar on Stand Up for Human Rights to NTB. So I will now hand over to the co-chairs, Dr. Teresa Kasaeva, Director of WHO's Global TB Program, and Dr. Ernesto Jaramillo, who is Medical Officer at the WHO Global TB Program. So over to both of you.
Thank you very much, Monica. Dear colleagues, distinguished partners, colleagues and friends. I am pleased to address you today on this important day when we stand up for human rights. Tuberculosis is one of the world's deadliest infectious killers. As we all know, it's deeply rooted in populations where human rights and dignity are limited. While anyone can fall ill with TB, the disease thrives on the most vulnerable, the marginalized, discriminated against populations, and people living in poverty. COVID-19 pandemic has exacerbated the situation even more, especially for the most vulnerable, where people affected with TB and COVID face dual burdens of stigma or barriers in assessing their right to health. Therefore, progress must go hand in hand with the other sustainable development goals efforts to reduce inequalities, eliminate extreme poverty, ensure social protection, and achieve universal health coverage. A people-centered, rights-based TB response is key. Alongside efforts to expand access to prevention and treatment, we must fight stigma and remove discriminatory laws if we are to achieve the targets and commitments we have made. As highlighted by our WHO Director General, Dr. Tedros, many times, health is one of the main rights. WHO was founded in 1948 on the conviction that health is a human right for all people, not a privilege for the few. Today, that conviction remains central to everything we do, and it remains central to the fight against TB. The promotion and protection of the human rights of people affected by TB is a legal and moral imperative and of crucial importance to ensure an effective response to TB. As you know, we have made significant progress in the fight to TB with over 63 million lives saved since the year of 2000. Yet the burden of suffering and death due to TB remains immense. According to our last global TB report, 10 million people fell ill with TB in 2019, and 1.4 million people lost their lives to the disease. Enough is enough. It's time for action to keep our commitments for the millions suffering with each day and their families. Human rights are at the core of the WHO TB strategy and the United Nations political declaration on the fight against TB. One of the key principles of the TB strategy calls for the protection and promotion of human rights, ethics, and equity. Political declaration commits heads of states, member states, to a comprehensive response that addresses the social and economic determinants of the epidemic and that protects and fulfills the human rights and dignity of all people. We urgently need to ramp up efforts and join forces. And we are to achieve these targets and commitments, including ending stigma and removing discriminatory laws to end TB. We need to close the gap and reach the millions of people who are currently left behind. An important step in this direction is ensuring the right to health for people with TB. This is part of what we are doing with the countries to strengthen their health system and help them provide progress towards universal health coverage. And again, as our Director General, Dr. Tedros told, universal health coverage without universal access for all people with TB to the quality services cannot be universal health coverage. Civil society engagement in achieving this is critical. And I'm very pleased to see today 2 members of our civil society task force for TB as a case speakers in this webinar. WHO Civil Society Task Force has been working closely with us to strengthen meaningful engagement of our colleagues in efforts to end TB across all aspects of WHO's work, including guideline development. I'm proud to join you all today to champion the rights of the most marginalized and vulnerable, to ensure they have access to all the services they need. For all diseases, including TB, especially in this challenging time. It's time to stand for human rights. It's time to end TB. Thank you for your commitments.
Thank you very much, Teresa, our dear director in the Global Tuberculosis Program. So we have over the next 60, 80 minutes, a collection of rich experiences that, as Teresa indicated, reflect the powerful role that civil society can play to ensure that our response to tuberculosis is really driven by human rights. Our first speaker comes from the Philippines, is Jeff Acabo. Jeff is a Filipino gay migrant living with HIV and a survivor of tuberculosis who has been advocating for the rights of people living with HIV in key populations and communities most marginalized. And he has been doing that since 2006. So he has developed a strong track record and is currently coordinating the Activist Coalition on TB Asia Pacific, and is also a member of the WHO Civil Society Task Force. Jeff, we have invited him to share with us his perspective why human rights should be driving the response to tuberculosis. Jeff, over to you.
Thank you so much, Ernesto, for that introduction, and for Teresa as well for setting the tone of today's webinar. A happy Human Rights Day to everyone who's tuning in and joining us today. So I was requested to make a presentation as to why we need human rights to drive the response to tuberculosis. But I believe that this debate is over. TB-affected communities, TB survivors, and civil society has long established the argument that the TB response is not only a matter of dispensing TB drugs to people, watching people with TB take their medicines in front of them, and assisting them to overcome the side effects in order to be fully treated with TB. We will not end the TB pandemic if we continue dismissing the fact that people are being missed by TB services, not because we have not been aggressive in finding missing people, as if it is our responsibility to find these people. Have we even asked ourselves what we expect when we actually find these missing people? Do we compel them to be screened for TB and take drugs against their will? Or should we provide them the information that they need so that they themselves can make those informed decisions and seek TB services? What human rights offers to the TB response is a change in the way we implement our TB programs. That our collective responsibility is not finding missing people. Rather, our collective responsibility must be determining what hinders people from seeking TB services and finding solutions that can enable people with and affected by TB so that they themselves can come forward and seek TB services. And these are linked to addressing stigma, poverty, and marginalization that are linked to human rights. Unfortunately, the stigma attached to TB due to the use of language, misinformation, and the lack of knowledge make those most affected by TB stigmatized and discriminated. A TB survivor that we talked to in the Philippines during the community rights and gender assessment that our civil society partner, Action for Health Initiatives, conducted in the country said that when he disclosed his TB status during a pre-employment interview, the company have dismissed him outright, which lost his confidence and affected his future employment prospects. And in many countries, including in a number of countries in Asia and the Pacific, and I'm not going to mention these countries, TB is still being used as a ground for migrants on whether they can be denied entry. Fortunately, we see some small progresses in the inclusion of human rights in the TB response. For instance, I'm actually quite happy to see that we are moving away from coercive TB treatment approaches, such as the direct observation therapy or DOT. Many reports and studies have shown that DOT can be intrusive and restrictive of people's rights that impact their ability to adhere treatment. And many health service providers, guided by the WHO ethical guidelines, are now working with TB survivor groups and civil society to provide information, and funders such as the Global Fund, who are providing enablers so that people with TB are the ones making informed decisions about adhering their treatment. And this is the centrality of human rights-based approach to TB, that the TB response must work towards strengthening the capacities of people with TB, TB-affected communities, and TB survivors, also called rights holders, to claim our rights and our entitlements, and for duty bearers, which is the state, to meet their obligations. What we do as part of the TB-affected community and civil society is we strengthen our constituencies' knowledge and capacity to understand human rights and how it can be applied in the TB response. So through APCASO, the organization that I belong to, who coordinates the Activists Coalition on TB Asia Pacific, or ACT-AP, and with the support of the Stop TB Partnership, we have developed a training manual called Right to Breathe, human rights training for people with and affected by tuberculosis. This training aims to build the capacity of TB survivors on human rights and use these capacities to hold government accountable through human rights violation documentation and advocacy. We have initially piloted this in Cambodia and in the Philippines, and we have recently conducted a virtual regional training of trainers from 4 countries. And we will be further rolling this out in 3 countries in 2021. That's in Nepal, in Papua New Guinea, and also in Vietnam. And this work is linked to a broader project that we are also doing, which is to develop a regional human rights agenda for action on TB, which is a set of regional priorities to transform the national TB response and align it with the human rights commitments made in the 2018 Political Declaration on TB. These progresses are worth noting, but if we are serious in shifting the paradigm towards a more human rights-based approach to TB, we have to strengthen the way we monitor our progress with regards to meeting our human rights commitments. Both the Global Plan to End TB and the WHO strategy to end TB has reflected human rights as key principles. But as long as we cannot translate these principles in ways wherein we can measure them, we will not be able to fund and implement human rights-based programming for TB. Member states have already made commitments from the 2018 Political Declaration, such as developing community-based health services that protect and promote human rights, and removing discriminatory laws and policies like what Teresa mentioned earlier. But after 2 years, I have not seen any document or mechanisms that monitor our progress in these 2 specific commitments. So I hope that the multi-sectoral accountability framework will be able to incorporate these commitments in its implementation. Let me end by citing Eleanor Roosevelt, who was a driving force in the crafting of the Universal Declaration on Human Rights, when she said that human rights begin in small places close to home. And for TB, it is also as small as changing the language that we use. And I think we can start exercising respect for people with TB if we can stop calling us patients, because this denotes passiveness and powerlessness. We are people with TB, we have rights, and we have the capacity to make informed decisions about ourselves, given the right support. The UN Secretary General progress report that was released in September has already made this milestone when we have been identified in the report as people with TB and not TB patients, except in citing one WHO guidance. And this is a crucial step for the TB response. So it is my hope that other stakeholders, including WHO, should do the same. Thank you so much, Ernesto. Back to you.
Thank you very much, Jeff, for your presentation with quite bold ideas that require a lot of work to be reflected in the reality. For the participants in the webinar, please be aware that we will be opening the floor for questions for the speakers towards the end of the webinar. So in the meantime, feel free to use the chat if you have access to convey your questions, and we will be collating that toward the end. So let's move from Philippines to India, where we are going to have a video recorded presentation by Priyam. Priyam is a lawyer working with the Global Coalition of TB Activists as legal support officer. She has been working on issues of public health with focus on access to medicines. Before that, she has worked with the former UN Special Rapporteur on the right to health on issues of intellectual property barriers. Priyam has been engaged very closely with the patient community in demanding an environment for equitable access to health tools and treatment in India, where there is important substantial progress in mainstreaming human rights in the response to tuberculosis, and has represented a community in legal challenge on violation of health rights in front of different authorities in India. So may I ask my colleague, Anna, to launch the video with her presentation? Thank you.
E, can you relaunch? We cannot hear sound. E, we still cannot hear. Can you pause? Can you stop sharing and share with Optimize?
Practices. Human rights based. Hello everyone. Thank you so much for inviting GCTA on this very important discussion on human rights based approach to tuberculosis. What human rights based approach to tuberculosis does is that it ensures participation, empowerment, non-discrimination, and enhancement of public health and good clinical practices. Human rights-based approach to TB has also been recognized in the WHO End TB strategy, the UN Declaration on the Fight Against TB, and Stop TB Partnership Global Plan to End TB 2018-22. I will now proceed to share the slides where I will be speaking about the technical brief that we have prepared. I will go on to share my screen. The idea of the brief that we developed, which is activating a human rights-based tuberculosis response, was to basically provide a clear and actionable guidance to tuberculosis policymakers and program implementers on how to activate a human rights-based response within the program, and also to highlight the 5 essential human rights, try to explain the content of them, and also the legal foundation on the basis of which they can be applied to the tuberculosis programs. Now, what is a human rights-based response? A human rights-based TB response would mean ensuring that the dignity and autonomy of the people affected by TB is there all the time, and that the patients and the people affected by TB play a role in all aspects of disease response, that they are asked and sought of their opinion at each stage where they seek treatment and care. A rights-based TB response places focus on the key and vulnerable communities and populations to ensure the special needs that requires their attention. And the response also demands a gender-sensitive response, and it leverages existing laws to strengthen the response. The rights-based response also focuses on right to health, right to non-discrimination, right to privacy and confidentiality, right to information, and right to liberty. And the reason why human rights is the best buy is because it will ensure development of everybody. Coming to the focused rights that we have spoken about in our brief, right to health. Right to health means right to have access to affordable, right to have affordable drugs, right to have availability of these drugs, and right to have access to good quality of vaccines, drugs, diagnostics to prevent, diagnose, and treat latent TB infections, TB diseases, and drug-resistant TB. The right to access health also includes the right to access health facilities where one can obtain good quality, people-centered care from trained healthcare workers. When we speak about right to health, during the course of the development of the brief, we spoke to several community members, and there were several examples that came out how people-centered approach is not taken. And this is one of the instances where Fumeza from South Africa shared that it took more than a year of taking the wrong drugs. And I had lost my hearing before I was correctly diagnosed with XDR-TB. Overall, I had a 3-year and 8 months long grueling experience with TB. And why we speak about right to health in this context is When the patients themselves are involved in the decision making, there'll be better understanding of what kind of treatment would be required for them to improve. So when we talk about incorporation of right to health in the TB response, it would mean creating TB Technologies Task Force, eliminating intellectual property and patent barriers, which pose price-related and access-related barriers, reviewing and developing national strategy to identify and eliminate all physical, financial, systemic, and gender-related barriers, and engage and empower with communities who are affected by TB to bring them to the forward and put them at the decision-making tables. Right to be free of discrimination. Right to be free of discrimination is based on the fact that no one should be discriminated on actual or perceived health status in both public and private spheres. And it is very important to ensure that there's no discrimination against TB-affected key and vulnerable population. Even in the technical brief, while we were conversing with different people who were affected by TB, there were several people who were denied of treatment because they could not, they did not belong to a particular region, or that they did not possess a certain proof of ID. And to be free of discrimination would require an approach where the policies ensure that there is prohibition, explicit prohibition in law and policy of all forms of discrimination. And when we provide recommendations on what could be included in the policies, we also want that there is a review, revision, and replacement of all stigmatizing language. There's also a necessity to mandate and provide recurring training for all TB healthcare providers to ensure that TB-affected persons are provided with care which is people-centered, and also to undertake periodic national TB assessment to see where we stand and what actions will have to be taken to improve this. So again, this is an example where Prabha has pointed out that she knows so many people who are suffering from TB that they don't even want to get tested. And the fact that the first point of care where they should be getting tested is itself creating stigma, creates the further fear of discrimination and stops the effective implementation under the TB program. The next right that we have spoken about is right to privacy and confidentiality. People affected by TB have the right to privacy in all the matters related to their health, to their records of their status, of whether they have TB infection or disease. And this right to privacy and confidentiality should also be present in the very design and implementation of active case finding, contact tracing, and other public health intervention that's taken by the authorities. And all the TB affected persons must be protected in healthcare and research settings where information related to digital health and medical records are collected, stored, processed, or transmitted. It should be ensured that there are policies and laws that require and obligates the authorities to keep these data related to health confidential and private. And when we talk about confidentiality and privacy, we have this huge question of how to maintain it, because as Dr. Jennifer Furin points out, in her experience providing TB care around the world, there is no protection whatsoever for privacy and confidentiality. The very signs on the clinics and the vehicles for the community work, they reveal someone has TB. So how do we overcome this issue of confidentiality of people who would want to have access to the TB services, to TB care, to TB treatment, and at the same time, not lose their privacy and confidentiality? And for that, we recommend that there's a need to protect the right to privacy and confidentiality, which would involve requiring all healthcare providers and program implementers to obtain explicit informed consent from those who are affected by TB while using their data or sharing their data with any other third party or making it public. Designs and implement policies, protocols, and practices for digital privacy and security, which would require further work to ensure that there are in place protocols that can be used at the TB policy level. Review and supplant all physical infrastructure that includes about privacy and confidentiality. There have to be resources that allow retention, storage of these data in a manner that they are protected. And also recognize and protect the right to privacy and confidentiality in employment, education, and housing settings. Another very important factor that comes when we talk about right of persons affected by TB is right to information. For instance, the example that we have here is nothing. They gave me no information when I was diagnosed with TB. And this is what happens with most of the TB affected persons. They do not know what they have. They do not know whether they'll be treated of it. They do not know if they will be infectious after a particular period of time, whether it's easy for them to move around, interact with people. And therefore, right to information becomes quintessential to be a part of the TB program. Right to information for a person affected by TB would include access to information about TB infection and TB disease, including prevention, treatment, symptoms, transmission, infection control, and duration of infectious drug resistance, and that TB is a curable disease. Information should be readily available and easily accessible and understandable in a manner and language that is known to the person who's affected by TB. What do we recommend for the right to information to be incorporated in the TB policies and for the TB policymakers? That there has to be a design, mandate, and provision for training all health care providers of TB on the provision of gender and culturally sensitive information. And there's also a necessity to establish, recruit, and activate a workforce of professional psychosocial counselors and peer-to-peer counselors at TB centers. The next is right to liberty. When we talk about right to liberty, what we mean is no person who's TB affected shall be arbitrarily or discriminatorily detained, including in case of involuntary isolation or treatment. Even if there is involuntary isolation, it is only permissible as a measure of last resort in very narrowly defined circumstances for the shortest duration possible and only to protect the public's health. And involuntary isolation can never be used as means of convenience or punishment. Forced treatment of people with TB during involuntary isolation or hospitalization or under any circumstances is not to be justified ethically, and in all cases, it is a violation of human rights. The policy should explicitly provide that involuntary isolation cannot be allowed except in very particular circumstances. The brief goes on to recommend certain aspects that can be looked at by the policymakers, which is develop and implement a human rights-based, people-centered policy isolation and involuntary isolation or hospitalization, create an independent national body comprised of physicians, lawyers, human rights experts, and TB survivors to decide request for involuntary isolation, explicitly prohibit involuntary isolation or hospitalization of people with TB in prisons as well, and also establish national law and policies which affect the people affected by TB in a way that they would be able to appeal before a court of law any decision of involuntary isolation. These are the core rights that we have identified in our technical brief that could be looked at by the policymakers. We would like to thank Professor Brian Citro and the Northwestern Pritzker School of Law Center for International Human Rights for working closely with GCTA while developing the content for the technical brief. We would also like to thank our institutional partners, Stop TB Partnership, for their inputs. But we would especially like to thank our community partners affected by TB for their valuable inputs in helping us putting this together so that the policymakers can build in a human rights-based response to TB. Thank you very much for patiently hearing this. I hope all of you have a very fruitful discussion. Thank you.
Thank you very much, Priyam. Actually, I understand that you have now joined us live to the webinar, so might be able to take some questions. And thank you as well for walking us through this powerful collection of fundamental rights that have to be protected and promoted in the response to tuberculosis, and that are somehow guiding a substantial amount of work in India. So now let's move to Africa. Actually, a violation of human rights that occurred several years ago was one of the factors that triggered a powerful response from civil society embraced by the government and particularly by the TB program. We are very much pleased to have in our webinar today a representative from the National TB program, who happen to have the role of coordinator for gender and human rights. Imagine a tuberculosis program that has a position with that name. That reflects an important level of commitment to mainstream human rights. So Kirote is a public health system specialist that has extensive experience in tuberculosis, both at policy and implementation level, and is coordinating not only the human rights, but also the PPM, public-private mix, in the National Tuberculosis Program. So she will be sharing with us how Kenya has been standing up and taking the agenda of human rights forward within the response to tuberculosis. Floor is yours.
Thank you so much, Ernesto. I'll be sharing my screen. It's such a pleasure to be amidst all of you today to discuss about human rights that play a key role in effectively managing tuberculosis. To start with, I'll share with you a story about a young Kenyan girl I met when I was doing one of my studies in an informal settlement in Kenya. This girl, Sisi, was 23 years at the time I met her. She's just been diagnosed, she had been diagnosed with TB 2 months earlier and had just completed her intensive phase of treatment. She was working in a nearby factory, and she says when she was diagnosed with TB, TB was screaming on her face. It was too much to bear. It just screamed out too loud. And she said, I didn't have HIV. How come I was being diagnosed with TB? Well, she started treatment, and after 2 weeks of starting treatment, she felt better. Of course, because she was getting daily wage, she couldn't go to work for those 2 weeks because she really was unwell. But before she was diagnosed with TB, she had come to the facility up to 4 times before she was diagnosed with TB. And when she was finally diagnosed with TB, she was started on medication. And 2 weeks down the line, she felt better. So she went back to work and just kept it silent because she knows the company policy does not allow people who have TB to continue working. So with this, she interrupted treatment. And the healthcare workers noticed that she hadn't come to pick her treatment after 2 weeks. But why? It is because she got out of work very late at around 6 p.m. Well, the facility closes at around 5 p.m. So she couldn't pick her medicine. So the government has put structures in place, a community unit, a CHV to be able to track anyone who interrupts treatment. So what do the facility do? They sent a community health volunteer to look for Sisi. When they went to Sisi's house, she was very shocked. You know, she actually felt like her privacy had been invaded. Why would they send someone to come looking for me? Everyone in this community knows that this is a community health volunteer. She could become, you know, people will know eventually there could be something wrong with me, yet I didn't want anyone to know. Eventually, anyway, she went back to treatment and was supported to complete treatment. Earlier this year, sometimes back like 2 months ago, in our local diaries, one of a software engineer spoke about his story on being diagnosed with TB during COVID-19 pandemic. He said he felt like he was caged after being diagnosed with TB. For him, he had symptoms, cough, and he associated it with COVID, so he didn't go to seek care. Why? This could be COVID, it will go away. If anything, people who are testing positive for COVID are being taken into, you know, quarantine. Those were the earlier times. So I don't want to go there. So I'll just keep quiet about these symptoms of mine. Eventually I'll do well. I'll just do some, what we call in Kenya dawa, some herbal, you know, concoction, and I'll feel better. But after 2 weeks, Pete wasn't feeling better either. He had night sweats, but it is the weight loss that bothered him. I haven't had weight loss in this COVID-19 symptoms, so how come I'm losing weight? So Pete visited a health facility, and for him, he was diagnosed with TB at the very first time he met a healthcare worker. But when he went home, his utensils were isolated by his family. He was even given schedules to have some sunshine. But he said he just felt so caged. It's within a pandemic, he's been diagnosed with TB. How does this go? But he was somehow happy that he wasn't working, you know, he was working at home at the moment. So he didn't need to tell his human resource manager that he was suffering from TB because, again, it meant something else. But what we realize, it's not all about dispensing medicine that matter. It is about providing these services with dignity. And these two stories illustrate what there still exists in our system. In Kenya, we continually miss nearly 40% of our cases that go undetected and untreated, which is a violation of the human rights. Yes, health should be for all. Just like Pete and Sisi, TB is high in Kenya among the most economically productive age group, between 15 and 44. And as much as it remains a public health concern, most men are affected by TB, but it is the women who end up suffering a lot of injustices because of TB. I'll talk to us about where we've come from as a country. And to begin with, we promulgated the Kenyan Constitution in 2010. When we had this constitution, when it recognized the government and other stakeholders were able to come up with a constitution that was, you know, people-driven, and a lot of civil societies coming in to ensure that we have a good Kenyan constitution, and we launched it, you know, in a flamboyant way in 2010. This constitution recognizes that the aspirations of all Kenyans, you know, to have good quality life. And the government is based on essential values of human rights, equality, freedom, and democracy, as well as social justice and the rule of law. In 2013, we came up with a patient charter. This patient charter was majorly, you know, a contribution of patient groups, implementing partners, the civil society, the WHO country office, and Global Fund. that helped us come up with this patient charter that outlines the rights of patients to access care, and upholding that healthcare is a constitutional right that should be provided by everyone. In 2016, Kenya was on the map again and all over the world in discussions about a ruling that was done by the High Court on TB is not a crime. The High Court of Kenya annulled the confinement of TB patients who interrupt their anti-TB medication that were initially being put in prison, and declared that it was unlawful, and unconstitutional to put them in prisons just because they had interrupted treatment. With this, the Ministry of Health was tasked in coming up with an isolation policy on how best to ensure that patients continued with their treatment. And again here, the civil society had really done a major drum up to ensure that patients are treated with dignity. And we stop putting patients in prisons when they interrupt treatment. Again, it's their right. Just like Jeffrey said, you can choose to take this medicine or not. So we just need to provide information for you on how to best do it. In 2017, we did a patient cost survey that we realized majority of our TB patients suffer some catastrophic costs due to TB, and the major costs drivers were the non-medical costs. So how is it then we are providing TB services for free, but yet our patients suffer catastrophic costs due to TB? So again, the TB program and the Ministry of Health with the civil societies, the WHO country team came up together again and put together a patient and a guideline that will be able to help us, reduce the catastrophic cost that is suffered by TB patients. Of course, in this patient cost survey, we also found out that most of our TB patients, again, were suffering a lot of social exclusion that we also wanted to ensure. Again, a lot because of stigma and discrimination. Then in 2018, the civil societies did some legal environmental assessment as well as some gender assessment that examined the national and legal policy frameworks, and with it identifying stigma as a major barrier towards accessing the TB services, among other things. Then in 2018, a government brought up the universal health coverage, popularly what we call the UHC. Then the UHC, this was meant to provide healthcare to all members of the population based on a principle of equity and solidarity. And this is what has enabled us bring, primary health care, provide these services more to the people. In 2020, the Ministry of Health Kenya and the Global Fund and Breaking Down Barriers Initiative conducted a baseline assessment of provision of services. And it has provided intensive support to Kenya and other countries to be able to come up with comprehensive programs to reduce human rights related barriers. Among the barriers they noted were, again, some punitive laws that were still existing, stigma and discrimination, among others. We have the National Strategic Plan 2019 and 2023 that acknowledges the human rights barriers interfere with the effective prevention of and diagnosis of TB, as well as adherence to treatment. There was a collective effort, both from the TB patient groups, the civil society, the government of Kenya put in a lot into ensuring that we come up with this strategic plan, The WHO country team provided technical support as well as Global Fund, so that we are able to ensure that as we deliver these services to Kenyans, we are giving them in a human rights-based way. The National Strategic Plan acknowledges that stigma, again, and discrimination, as well as other human rights barriers, interfere with the effectiveness of providing these services. And so we ensure that we have a desk, one, to coordinate the human rights response towards TB, as well as ensure that all programs that we, and all interventions that we put in place are gender sensitive, are of equal measure, and everyone can access them. So what have we done? Just like I had earlier spoken about, we came up with an isolation policy. This was possible because of a lot of support that we got from the civil society here to ensure that we came up with an isolation policy that ensures the rights of TB patients are protected, as well as ensuring that those people who interrupt treatment are encouraged to complete treatment in an appropriate medical setup. We also came up with a social protection policy. Here is to ensure that we are cushioning the TB patients, most who are vulnerable, which are the drug-resistant TB patients, from continually being impoverished. We have a cash transfer program that we give to our DRTB patients to be able to cater for transport to go to the facilities to get medication, as well as ensure that they're linked to a national health insurance fund that enables them to get additional services within the facility, the hospitals, while they're on treatment of TB. We've built capacity for TB service provision in prisons. We realize a lot of violations happen here again. It isn't enough that first they have been put in prison, but they also should access services. So we've built capacity within the prisons to be able to provide these services to all persons who are in prisons. We have an integrated TB HIV programming to be able to address human-related barriers to both TB and HIV. We realized that a lot of stigma was coming from the fact that people associated TB with HIV. And so we really needed to integrate our services further to ensure that our counterparts in the HIV programming tackle the stigma, then we also are ensuring that we delink the two and and give information to our TB patients that you could have TB but not have HIV, and TB is curable, and basically provide this information. We've been training the healthcare workers on human rights and medical ethics, first to be able to recognize that as they offer these services to the TB patient, they offer these services with a lot of dignity. Just like in CC point, being able to provide the services with some privacy, provide this information because that is what they lack most of the time. And as they recognize the human rights violations that could be happening, then they are able to prevent it. Human rights is more about preventing it rather than acting upon it. We've also been able to empower through the Stop TB partnership in Kenya to empower the TB communities to participate in TB allocation within the devolved functions of the government, the counties, such that they are aware that we need to drum up more support to, for domestic funding, for TB allocation within the devolved functions of health systems that is being done by TB affected communities. We have a national network of TB champions that we've been engaging, one, to be able to recognize where the human rights violations are, and as they continually offer psychosocial support to, within their network, to be able to recognize and report these human rights violations through their network. From that, we also have trained the community health volunteers in about 4 counties that we are hoping to expand to be able to recognize these and report using an app to monitor the human rights violations in health facilities and link them to legal, to lawyers that we've also sensitized on human rights violations, again, for TB. We've had managed through our local partners, AMREF, through the support of Global Fund, to train lawyers who can be able to take up these cases and litigate against. We've held 2 successful legal aid clinics that were organized by the patient support groups and the lawyers that we have trained, to provide this legal information to them so that they are also aware of what it means. Then we've had some gender sensitive programming and intervention, especially for men. As I had earlier said, TB is more among men than women in our country. And a lot of it we've done into the programming into the informal sectors and the transport sector. This is where most of our men are. We have had some innovative challenge fund that we put to be able to identify men in their workplaces so that we go to them rather than waiting for them to come to us. We provide these services to them. We've also had this app that I call the iMonitor that ensures that we document all these violations that happen within the health facilities. And then we formed a multi-sectoral partnership between the Ministry of Health and other departments so as to be able to ensure that we have collaborative efforts towards this ending TB and, someone to be accountable of all the issues that we've put in place and we've said that we are going to do, be able to do them. Our NSP recognizes some of the areas that we need to intervene on. And these are some of the intervention areas that we are focusing on moving forward. One on stigma and discrimination reduction. I'll be speaking about that later on how we are going to do that. Then human rights and medical ethics related to HIV and HIV-TB for healthcare providers, for them to be able to recognize that they could be, the ones violating the rights of patients. Then sensitization of lawmakers and law enforcement agents. This is including those that are manning the prisons. And the legal literacy. This is the know your rights, just to basically ensure that we're providing as much information as possible for people to be able to know what it is that entails the violations or what best can we do. Then, of course, the legal services, we hope to continue sensitizing more lawyers to be able to recognize these and provide support for this. Among the barriers that were identified by the assessment that the Ministry of Health Kenya and Global Fund did was that there still exists an implementation gap as we did the isolation policy. So it's just a matter of improving the laws and the regulations as well as the policies that we have to ensure that everyone then knows it's their responsibility to be able to do this. And then lastly, but not least, reducing the gender discrimination and harmful gender norms against women together with HIV programming. In specific, we hope to conduct a community rights and gender assessment in Kenya, just to know what is it that really is all about the gender barriers in our country. This assessment will seek to understand the factors that increase vulnerability within specific communities and individuals, as well as the vulnerable population, and be able to tailor specific interventions to provide preventive diagnosis and curative services. Then we do not know yet as a country our stigma index for TB. We hope to conduct a stigma assessment and also be able to have interventions to reduce stigma and the same. Basically to understand the types of stigma, the sources of stigma, and that are related to TB, and have interventions specific to that. Again, we also have to have, hoping to have the targeted multi-sectoral media campaigns, both at the national and the devolved function of the government, on human rights messages to TB and HIV. We realize a lot of human rights violations are happening because of information, so we hope to provide this. Then integrated training on stigma and discrimination, human rights legal literacy, again on our isolation policy, on how best to do the referrals, the legal services for both TB, HIV, and drug-resistant TB.
Sorry, Kirote, 2 minutes more. Thank you.
Yes, thank you. Then again, strengthen the communities of engagement and accountability mechanisms, and also be able to have a very strong community-based monitoring of TB related to stigma and discrimination, and develop and disseminate a workplace policy through a multi-sectoral approach. So in basic, this is what we desire as a government to achieve: a multi-sectoral accountability mechanism and framework that holds various duty bearers to account. Also be able to understand the factors that increase vulnerability and react to them, and also be able to reduce stigma and discrimination related to TB. I'd want to end with a story that was told by one of our famous African daughters, Wangari Maathai, of a hummingbird. And to know that we can make a difference through progressive change like the bird did. We all will achieve NTB targets if we promote human rights-based approach towards ending TB. Thank you. Back to you, Nest.
Thank you very much. I mean, it's really impressive. I mean, I cannot imagine a few years ago that we can have a national TV program with such a progressive agenda in human rights and tuberculosis. You made reference several times in your presentation about the crucial role of civil society in supporting the government to develop this agenda. I wonder if that is true. So I would like to ask Evelyn to share with us her perspective in all this work, and if it is true that civil society really did something worth to be mentioned in this webinar. Over to you.
Thank you so much, Ernesto, and thank you for this opportunity. And Kirote, thank you for taking us through what the government or the TB program has been able to do. Allow me to just give a brief history of how far we have come as a country, and also mention what has been the role of civil society in all this. I've been engaged in TB advocacy in Kenya for over a decade now. And when I started doing advocacy, I would refer those days as the dark days as far as human rights for TB patients is concerned. For example, for MDR TB patients, that's about 10 years ago, for them to access treatment, they were required to meet some conditions. And some of the conditions were quite punitive. I remember meeting with this young man who had just been diagnosed with MDR TB. His name was Walter. The conditions Walter was given for him to access treatment for his MDR TB treatment was: one, he had to come with a letter from the chief. That is a chief acknowledging that, yes, I know Walter, he comes from my village. Then he was required to come to deposit a minimum of $1,000 and come with a depositing slip. That was to demonstrate that he is able to support himself throughout the treatment period. 3, he was required to come with a treatment supporter who would sign a document saying, I agree that I'm going to support Walter throughout the treatment. And the final one was that he was supposed to relocate from his village and come to Nairobi, that's the capital city of Kenya. And from his place to Nairobi is about 300 kilometers. but he had to relocate and come and live in the capital city for the period of 2 years when he was receiving treatment. And these were the conditions that were given to all MDR-TB patients before they could be initiated on treatment. Your guess is as good as mine that so many patients may have died because they could not be able to meet those conditions. Walter was lucky. He's still alive today to share his experience. On the legal framework, like my dear friend Nkirote has alluded to, the Public Health Act provided for imprisonment of TB patients who are not able to comply to the treatment. Fast forward, about 10 years later, what is the situation and what was the role of civil society? I'll not dwell into so much into what has been put in place because Nkirote has mentioned it. But let me just mention a few. We don't take it for granted that the National TB Program decided to have a human rights desk at the National TB Program. We now have access to all patients, including MDR-TB patients, can access treatment unconditionally. They don't have to come with deposits, and treatment was decentralized to all the counties. So they don't have to come to the capital city to access treatment. We also have all the MDR-TB patients getting their allowances to facilitate them to access treatment. Over and above that, all the TB patients, drug-resistant TB, are all enrolled on NHIF to support their treatment for the period that they will be on treatment. We have very empowered patients communities. We also have a body of pro bono lawyers who have been sensitized around human rights for TB patients and who step in whenever there is need for them to go to court. For them to do litigation. I can give an example of how having an empowered community has transformed the human rights landscape. Recently, I received an email from one of the patients' communities, a member of the network of TB champions that Nkirote has alluded to. And he had identified a TB patient who had lost her job when the employer realized that he had TB. We are currently looking for a pro bono lawyer to take it up. If we didn't have a body of empowered community, such a case would not have been identified. We have all the research that has been done, the legal assessment, the legal assessment and the gender assessment. And we can say, right, we have a policy framework in the country to address human rights for TB patients. So what has been the game changer? What has brought all this change that has taken place in about 10 years? One, an empowered body of TB communities. We had to do a lot of, as civil society, we had to do a lot of sensitization and empowerment of TB communities for them to understand the whole concept of human rights and to know that they have a recourse. They have a legal redress that they can follow to ensure that their human rights are not being violated. We started with the Patients Charter. Again, Nkirote has mentioned it. We had a Patients Charter which we disseminated to different civil society organizations and TB communities to let them know their rights and their responsibilities and the steps they could follow if their human rights were violated. So patients communities were empowered, civil society who are empowered as well to identify what constitutes human rights violation for TB patients. I would also say that we had political support. It may not have been 100%, but we can probably say that we have quite political support. One, for the government or through the Ministry of Health to agree to respond to the court ruling and agreed to come up with an isolation policy as a result of a court ruling on TB. We termed that as political support, which is very, very important. We also have a human rights caucus in Parliament, whose members of Parliament have been sensitized on human rights issues for TB and HIV. And of course, we have the TB caucus, whose chair, Honorable Mule, personally sat in the development of the social protection policy. And again, his interest was to ensure that the content was right to be able to address the human rights issues. Again, we really want to appreciate the generosity of the organizations that have come in, one, to provide resources to empower the TB patients, the TB communities, and the communities and the civil society, and also support conducting the research that has been done. For example, Stop TB Partnership that has been very supportive, even in empowering the communities, and also Global Fund that has supported in, for example, training of the lawyers, training of the healthcare workers in human rights. Now, what is required? We've talked about the game changer that brought all this change, but as a country, we cannot say that we are yet there. We still have gaps. For example, much as we have the isolation policy, it has not been fully implemented. We still have so many counties that have not yet put up an isolation policy. So gaps still exist. We still have many people who are not still aware about the human rights. So there are still huge gaps. So what needs to be done? Number one, we need to invest heavily in creating awareness. For me, I say we need to prevent human rights violation before it happens. And one of the reasons why it has been happening is because of lack of awareness. Like I have been involved in the training of the healthcare workers in human rights. And one of the things that they have said is that when they are doing what they are doing, they do not know that it constitutes human rights violation. If they are aware and they had other options, they would have taken up the options. Number two, we need to expand human rights-based programming. That would mean we have we expand, for example, the access to the free legal services whenever we need them. We also need to expand the program to make sure that we are reaching all the populations. Number four, much as we have research that has been done, the legal and gender assessments, Mikrote has said that we still need, for example, a stigma index survey. We have been fighting an animal which we don't know the magnitude. We don't know the size of the elephant in the house, which is stigma. We need to invest in conducting a TB stigma index so that when we are doing interventions, then we know the magnitude of the problem that we are addressing, especially as civil society. We also need more funding for communities. Like I've said, much of these changes has been brought about by either the interventions by the communities and civil society. So we need more empowerment. We need to increase the number of those who have been empowered, both in the communities and also the civil society. And finally, it takes me and you and me to realize and recognize the violation of human rights. So I would say we also need to take it as a personal responsibility. My fellow advocates, my fellow communities we are in this war together, we take it as a personal responsibility to ensure that no person with TB fails to access services because of violation of human rights. We need to make it a personal responsibility to ensure that nobody suffers human rights violation. Like the stories you've had, they're so humiliating, they're so demoralizing. We need to make it a responsibility to leave a legacy so that the people who come after us, they will say, we are enjoying freedom we are enjoying lack of human rights violation because somebody who was ahead of us made a sacrifice, made a commitment to ensure that we eliminate completely violation of human rights. So I would really want to take this opportunity to thank the civil society organizations and communities in Kenya that have been working very, very aggressively to bring forth the issues of human rights, and organizations like Kellyn, who actually the ones who took it upon themselves to take the case to court and have been following up on a violation of human rights, and all the pro bono lawyers who have been trained and who have been on standby, and they have sacrificed their time so that we can run to them whenever there are issues of human rights violation. So I will stop there. Thank you so much. I really appreciate this platform. Thank you.
Thank you very much, Evelyn. Evelyn is a global health advocate with a key focus on tuberculosis, and since 2015, she has been serving as the Chief National Coordinator of the Stop TB Partnership in Kenya, and also member of the Civil Society Task Force of the Global Tuberculosis Department of WHO here in Geneva. So it's fascinating really to see this productive collaboration between the civil society and the government, and to have a productive impact, to have a difference in the lives of people. Health is a human right, hence is enshrined in the Constitution of WHO. So this webinar would be incomplete without having the chance for WHO to present what is ongoing at the moment in the organization to support member states and to promote the uptake of human rights in everything we do in health, and in this case, particularly in tuberculosis, of course. So I'm pleased to invite our colleague Rodney Court, who is a senior consultant in the Human Rights Gender Equity Department here in Geneva, which reports directly to the Director General. Over the next 10 to 15 minutes, he will be sharing with us then also what tools are available and how we can take advantage of those tools to make a difference in the life of people. Over to you, Rodney.
Thank you very much, Ernesto. And I want to take the opportunity to thank the WHO TB program for the opportunity to present. And I also want to congratulate the Stop TB Partnership on the excellent technical brief I reviewed that has a very strong human rights focus. One of the things that I'm struck by is my background is very strongly in HIV. But what is striking about the context of TB is the extent to which, like HIV, it follows the social fault lines of human society. So it disproportionately affects people and groups who are facing pre-existing discrimination, stigma, and human rights violations. So congratulations on an excellent brief, and thank you to the participants in the seminar. I'm going to try, I'm not that used to Zoom, so I have just a few slides that I want to pull up. So I will see if I can do that competently. Okay. Okay, so my apologies if you're seeing part of the edge too. I want to talk just at the very start about the right to health and the standards in terms of the right to health, the principles and the legal obligations of member states. And those rights are defined in a number of international instruments, as well as regional instruments and a lot of constitutional arrangements. And they require that health services be available, they be accessible in terms of non-discrimination, physical accessibility, affordability, and also information, as well as being culturally appropriate and gender sensitive. And finally, be equality in terms of safety, effectiveness, people-centered, timely, and equitable. And some of the core principles based on the international instruments include equality and non-discrimination, which is a legal obligation as well as a principle, and it prohibits discrimination on the basis of a number of grounds, including the ones you see there. And it also prohibits discrimination, whether it's direct or indirect. And I think that's really important in terms of laws or policies that may be facially neutral, but actually are either applied or effectively have the effect of discriminating against individuals or groups. Secondly is meaningful participation. And some of the presenters have talked today about the critical importance of the engagement with civil society groups and other stakeholders that are affected by policies and programs. And I think it's vital that they be engaged with the assessment, design, implementation, monitoring, and evaluation. And that's one of the principles, as well as accountability. And in terms of accountability, I think it's also important to point out that states and other duty bearers are also accountable for preventing third parties from violating individual human rights. I want to talk just a little bit now about the context we are in now, which is COVID-19 and the pandemic. There are a number of policy briefs on this slide that speak to the human rights context of COVID-19. And it includes the Secretary General's call to action, the UN policy brief on human rights in the time of COVID, which includes a strong focus on healthcare system and health services, and the UN checklist for a human rights-based approach to socioeconomic country responses to COVID-19. And the first pillar in that framework is on health services and equitable access to health services. One of the things I'm sure people on this call are aware that has happened is that essential health services have been disrupted. So one of the things WHO has done is to provide guidance on the essential health services that are required in the context of COVID-19, including TB services, services for HIV prevention, treatment, and testing, and other essential health services. Finally, I just want to talk a bit about the impact of COVID-19 in the context of the human right to health. There's a lot of evidence around the impact of lockdowns, curfews, and other emergency measures having a disproportionate impact on people who face existing inequalities, discrimination, and socioeconomic marginalization. The COVID-19, the World Bank estimates, has driven close to 100 million people further into extreme poverty, which again is one of the major factors in terms of poor access to health services and poor health outcomes. I want to talk a little bit about criminal law sanctions in the context of TB, in the context of HIV, and now in the context of COVID-19. A number of jurisdictions have applied criminal law sanctions, which, as Dr. Tedros has indicated, along with OHCHR and UNODC, is both counterproductive as a public health measure and raises serious human rights concerns. And it's perhaps unsurprising, but disappointing that a number of member states have resorted to penal sanctions as part of their response to COVID-19. Finally, I just want to flag that any emergency measures, even in the context of a significant public health threat like COVID-19, need to respect the parameters of international human rights law and the Syracuse Principles, which require that any limitations on those rights for which limitations are permitted, such as freedom of association, most obviously, but also aspects of mobility rights, be necessary, proportionate, that is the least intrusive measure, time-bound, reviewable by an independent court, and most importantly, non-discriminatory, both facially and in the way in which those measures are applied. And unfortunately, we have seen a number of reports of emergency measures which are applied in a discriminatory manner, and again, a disproportionate impact the poor and people which face pre-existing stigma and discrimination. And finally, I just want to quickly flag there are a number of policy briefs, tools, and other resources that WHO has produced here in Geneva, but also a number of regional and country level resources that are available on the website there. One of the things that I think it's important to do is ensure that those tools are available to people working at the country level or at the regional level, and that the relevant public health data is incorporated. And I think I will stop there. That was a very kind of quick overview, but I'm happy to share the presentation and the links to the extensive resources that are available on the WHO website. Thank you very much.
Thank you very much, Rodney, for this overview of a very broad area of work. So we are now reaching towards the final stage of our webinar, where we would like to have your questions or comments to the speakers. So to kick off this, I would like to hand over to Monica Diaz.
Thanks so much, Ernesto, and thanks to all the speakers for excellent interventions. It's quite a wide range of experiences across countries, civil society, and of course our colleague Rodney from our colleague Rodney from WHO. So thank you so much. So as we've heard today, Dr. Teresa Kasayeva started the session outlining the importance of human rights, as well as how critical human rights is if we are to reach our targets. And we have targets to end TB as part of the NTB strategy. And we also have other targets in the lead up to, which are based on the NTB strategy targets, which are closer, which is the 2022 UN high-level meeting targets. So just this year, a month ago, we released a special report that WHO supported the UN Secretary General in releasing the Unsg Progress 2020 Progress Report on TB, which outlines priority recommendations that need to be undertaken, especially at this time while facing the COVID-19 pandemic, to accelerate progress so that we can get on track to reach the 2022 targets. And there are 10 key recommendations or 10 priority actions that have been put forward to countries, to partners, to the TB community, the world as a whole, to make sure we get on track to bring down TB that still remains one of the top infectious killers. So to kickstart the Q&A, let me come to one of the recommendations, the recommendation that focuses on human rights in the Secretary General Progress Report. And this is recommendation 6, which says the main focus is promote human rights, combat stigma and discrimination. And the recommendation says, given that promotion and protection of the human rights of people affected by TB is a legal, ethical, and moral imperative, and that people affected by TB continue to be subject to human rights violations, which together with stigma and discrimination impede access to care and add to the suffering caused by the disease. The actions that are recommended are to review and update laws, policies, programs to combat inequalities and eliminate stigma and discriminatory practices in the TB response, working together with civil society and affected communities, and with particular attention to vulnerable populations. Many of you have already spoken to this, from India to Kenya. We heard from Jeff as well. And also to ensure that national strategies, plans, policies, and other documentation avoid stigmatizing language. So it would be great if the panelists could kindly put their videos on, and if we could hear your perspectives on how you can see how we can work together to make this recommendation a reality. It's just come out last month, and we have 2021 to really rev this recommendation up to make it happen so that we can get to the 2022 targets. So perhaps I'll kick off with you, Ernesto, and then we can go down to country and civil society speakers. And then Rodney, if you could speak to the big picture, WHO as a whole, and how we can align and streamline efforts. So over to you first, Ernesto.
Thank you, Monica. We are short of time, so my answer will be in less than 1 minute. And I would like to invite my other colleagues in the panel to also not to go beyond 1 minute in the response. I think the main thing to do is to start with the change in the mindset that we need in the TB community. TB is not a medical issue. Medical issues are part of the response, but is fundamentally a human rights issue. And hence, we need to work with lawyers in the National TB program, with civil society, and not only with clinicians, in order to meet the demands of the people affected by the community. This is a fundamental challenge. Once we start to change our mindset, there will be a lot of beautiful things happening in the field. Over to the next speaker, Jeff.
Yeah, thanks, Ernesto. Just very quickly, as mentioned earlier, we are actually planning to develop a regional roadmap, a human rights agenda for action on TB, as well as a roadmap in 2021 covering some of the countries in Asia and the Pacific. But I think to complement that, we really need to have some sort of a monitor or a dashboard in terms of the progress in changing the laws and in introducing new laws and policies as well. And I really hope that at least for the 2021 or 2022, we will be able to see that kind of data in the WHO Global TB report, hopefully.
Thank you, Jeff. Over to you, Priyam.
Hi, thank you. In addition to what Jeff and Ernesto have mentioned, definitely lawyers have to be trained. I agree with that. And GCTA in the past 2 years have been training several lawyers on aspects of right to health-based approach to TB. But we also strongly think that there's a need to engage with the policymakers and each of the officials at different cadres within the program, because that's one of the places where it starts. When the program itself discriminates or violates human rights, that's when the lawyers come in. So apart from counseling and telling them, engaging with them, and how to ensure that patients are treated well, it should be approached from the point of view of rights and not simply what the disease is about. Thanks.
Thanks, Priyam. Over to you, Nikki Rote.
Thank you very much. I'd like to just add on to what Priyam has spoken about, especially about creating awareness to everyone, ensuring that we have created, everyone is aware of really what we want to do, and people know how to respond to violations. So it's not enough that you're providing medicine and, monitoring, providing dots, but rather we need to focus now on ensuring that we have dignity in how we provide these services. Most so especially to the healthcare workers, because most of them, most of the time, they do not recognize that they do not provide, they continue to violate human rights, especially when they do not provide the privacy, when they do not provide the information to the patient. Then it starts from there. We have to provide information, give a lot of information, then link the violations that happen later, prevent violations, but also linked to the violations that happened later to the legal fraternity to be able to provide that for us. But most important, it is to create awareness that we really need to focus on. Thank you, and back to you.
Thanks so much, Nikirute. And over to you, Evelyn, for your intervention.
Thank you so much. Let us stop it before it happens. And how do you do this? The awareness, awareness, and more awareness. And who can do this? One, an empowered body of communities. Two, an empowered body of civil society. And three, we need something to facilitate all this, and that is more funding to these two groups, the communities and civil society. Over to you. Thank you so much.
Thank you. Very nice, short, crisp, but to the point answers. Rodney, would be good to hear your perspective as well as we move towards greater promotion of human rights and ensuring a rights-based response. What would be your perspective or advice?
I think it's vital that the right to health is viewed in the context of other human rights, in the sense that human rights are interrelated and interdependent. So issues like access for prisoners or people of diverse sexual and gender orientations, advocacy on with parliamentarians, both in terms of proactive and in terms of litigation strategies are very important. So I would say that a recognition of the interrelatedness of human rights is vitally important in order to improve the agenda of health for all. Thanks very much.
Thanks so much. So very rich answers and yeah, clear path looking ahead. We have one more question, and this comes from Dr. Malgosia Gremska, who is our ex-colleague and who still remains a very passionate advocate for childhood TB. So Malgosia, over to you for your question, please.
Thank you, Monica. Thank you, Ernesto, and thank you all panelists, some of whom I met in my professional career in WHO. And indeed, I left WHO a few months ago, but I try to remind in this virtual contact with my colleagues as well as the global TB community. I am a member of the working group on child and adolescent tuberculosis. And the big concern that we see in childhood TB is that children who have equal human right to health do not have access to care. And I would like to ask you, the panelists, activists who fight for human rights of people with TB in your countries, how do you see this in your countries? Children die from TB, not even having had a chance to be diagnosed. So I'd like to hear a little bit of your comment. What is being done to improve this inequality in the access to health for the youngest members of your society? Thank you.
Thank you, Malgosia. Very important question. And I see that Jeff has already written in the chat a response, but Jeff, would you like to respond live as well, please?
Yeah, sure. Thank you for that question, Malgosia. Children do have the right to be informed of their TB status and how to access TB services. But at the same time, there is this magic number, which is 18, that sometimes becomes an indicator of what kind of information and service are to be provided. Maybe TB or other related health issues for children. But we'd have to understand that children themselves have different levels of maturity. So we really need to develop, and it is the responsibility of the service provider to develop age-appropriate information about TB. We also need to recognize that families have a social responsibility over their children, but in cases wherein parents or guardians will be the challenge in reaching out to the children, there has to be an option to consent to accessing TB diagnosis and treatment for children as an option if the adults would become a challenge in reaching to them. Thanks.
Thanks, Jeff. So would any of the other panelists from India or Kenya like to respond?
Yes, I want to respond to the issue of the rights of children. Jeff has said about their right to access to information, but I would want to put, I would want to mention something about a right to access to services for TB, for childhood TB. I realize that we are not really, we are sort of lagging behind in coming up with innovative technology for addressing TB in children, for example, diagnostics, and even access to these diagnostics, and also child-friendly formulations. For example, for DRTB, we need to have a more child-friendly formulation. Number two, we need to have free access for diagnostics for children. For example, in Kenya, and I'm glad that Inequality is here, we still charge for X-ray for children above 5 years. And that has made us lose quite a number of children because they cannot afford an X-ray, which costs almost $10 in our country. So let us be very conscious to ensure that, first of all, that children have a right to access to the best treatment, and that we should, as countries, provide exactly that. Thank you.
Thank you, Evelyn. Any other panelist would like to speak? Nikirote or Priyam?
Yes, thank you very much. So to begin with, as a country, we've been doing much for children. Building up diagnostic mechanisms that are friendly to the children, and the fact that it is their right first to access care. We have been thinking about and launched a TB preventive therapy policy that focuses a lot on, children get TB from adults. And if we have TB preventive therapy that is accessible, then we can reduce the chances of these children falling into TB. But Evelyn mentioned a very important thing about research and about innovative ways that we can have diagnosis for TB, especially in children. It still remains a challenge, especially for those who are bacteriologically confirmed children and under 5. It is a big challenge. We are seeing a lot of innovations for diagnosis that are coming up lately to be able to diagnose TB in children, and which we should be putting much more focus on, so that we make these services accessible for them, that are less intrusive, because we know some of these procedures then are intrusive as we try to get, the aspirate, the gastric lavage to be able to diagnose TB, and think of more easier ways that we can have diagnosis of TB in children. And I'm happy that, again, in the world, we are beginning to think about these technologies that we can come up with. A lot of research is going into it. But I would also want, to emphasize on the fact that TB preventive therapy can, make a lot of difference in children and adolescents who end up having TB. Thank you.
Thanks so much, Nikirote. I now look to see if there are any other questions, or Priyam, if you would like to add anything.
Sorry, I had gotten disconnected in between. I just want to add that in case of children, while there are innovative diagnostics that may be being developed, one of the problems that they face is inability to go back to their lives, of having lost time in going to schools or connecting with their friends. And what are the alternate models that can come up for children with TB, so that they feel like they're not cut out and come back to health faster with equal support of the society. So for that, there could be model guidelines or structures that could be suggested to the policy makers that they can look at. Thanks.
Thanks so much, Priyam. And Malgosha, thank you for this very important question. and hope that this can also be taken back to the child and adolescent working group on to put more of a spotlight on this issue as you look at rolling out the roadmap. So with this, I see we have no more questions, and as Ernesto rightly pointed out, we are indeed running out of time. So Ernesto, I'm happy to hand it over to you to summarize and outline next steps. Thanks, everyone.
Thank you, Monica. Probably, I think a big take-home message is that from the contributions of all speakers, there is strong evidence that is feasible to mainstream human rights in the response to TB, and that it is effective. It can make a difference, and we know it has made a difference in other diseases. HIV is the best example for that, and TB community should follow similarly and make of the whole response something driven by human rights. This is not going to be the last webinar on human rights in TB. Probably is going to be the first in a series of different seminars that we will be featuring the progress that countries and partners are making to make a reality all these documents that are signed by member states, but that need to be materialized, that need to become a reality in the field. Thank you very much to all of you, the participants, but also for the speakers for having accepted the invitation. And we look forward to continuing communication with you and to continue supporting people who want to be part of the response. Thank you very much. Have you all a very good day, very good week, and very nice weekend. Thank you. Bye.
Thanks, everyone.
Thank you.
Bye-bye.
Thank you. Have a good day.